call is now being recorded. So, hello, good morning. Presentation. Why my presentation? Come on. So, hello, good morning. So, I just wanted to start to share with you, as we all know, we have new cases, right, recently regarding mitral valve clipping. Last week, we have 3 successful cases, right? So I want us to review or have the idea what is mitral clipping or mitral valve clipping. So just inform me if in case my voice is not clear or there are some echoes or something disturbances regarding the lecture, okay? Don't hesitate to inform at the team. Okay, so now, so the mitral clip, a transcatheter solution for mitral regurgitation. So thank you for joining with me today. We're here to discuss a remarkable advancement in the treatment of heart valve disease, specifically the mitral clip, which is a transcatheter solution for mitral regurgitation. So what is mitral regurgitation? So in brief definition, it is an incompetent mitral valve leading to backward blood flow into the left atrium during systole. So this is backflow from left ventricle to the left atrium, probably due to some either mitral valve collapse or insufficiency. So mitral regurgitation, wait, sorry. Okay, so mitral regurgitation. So this is a common and often debilitating condition where the mitral valve, one of the heart's 4 critical valves, fails to close properly. So there is improper closure or what we call insufficiency. This leads to the backflow of blood into the left atrium with every heartbeat. Over time, this inefficiency places an enormous strain to the heart, leading to symptoms, leading to shortness of breathing, fatigue, and can ultimately progress to serious heart failure, pulmonary hypertension, and even death. Typically, this is what we call that divided into types of MR, which is two. First is the primary, which is degenerative. It is due to structural abnormalities of the valve, like valve leaflets, chordae, like mitral valve prolapse, cordial rupture, and we have the secondary, which is functional related due to left ventricular remodeling or dilation or dysfunction, leading to the leaflet teetering and incomplete coaptation with structural normal leaflets. Okay, for many years, the gold standard of treating severe MR has been open heart surgery. Either they are repairing the valve or replacing the valve itself. While highly effective surgeries carry significant risk, especially for our elderly. So the current management now is medical therapy, surgical repair, or replacement, which is the gold standard before but with a lot of limitations as well. Like as I have said earlier, which is the elderly, frail patients, highly comorbid patients who might have been inoperable, those patients who are really inoperable due to surgical risk profile. This is precisely where our transcatheter approaches it because it offers less invasive alternative. Same with our TAVI, right? So TAVI is transcatheter aortic valve replacement or transplant. Now we have also this transcatheter mitral valve implants. Okay? So this is precisely where the catheter therapies have emerged as a game changer. Thus, a transcatheter valve replacement revolutionized aortic stenosis. So now the MitraClip has also been transformed how we approach mitral regurgitation. It does not require surgery is not now the only treatment or management of MR. So it offers less invasive percutaneous option for patients who previously had very few safe and effective alternatives. So today, in cases, its mechanism of action is actually the step-by-step procedure. The crucial role is patient selection. So let's go back first with the pathophysiology of MR. So pathophysiology of mitral valve regurgitation. So this is our normal valve anatomy. So this is two leaflets, right? So we have the anterior and the posterior. Then we have this primary MR, meaning, as I've said earlier, primary mitral regurgitation are due to valve insufficiency. Like example, valve prolapse or flail leaflet, or there is a rupture. Then also this one is regurgitation wherein the leaflet is flail. It's going here instead of bilaterally opening and closing. This is an example of valve flail or leaflet, I mean. So now this is a functional mitral regurgitation. It is both functioning, but the chordae is not closing properly. Then this is the secondary, right? So the pathophysiology of mitral regurgitation really is knowing the normal function of your mitral valve. As I am always telling, you have to know the normal function or the normal anatomy for us to appreciate what are the abnormalities with the valve or any process in the body. Okay, so primary regurgitation or primary MR, the mechanism is that the most common cause of degenerative mitral valve disease, often referred to mitral valve prolapse. In here, in mitral valve prolapse, the leaflets or the supporting chordae become floppy. okay, elongated, or sometimes ruptured. So imagine a door with a broken hinge or a stretched rope holding in the shut. The same thing with our CCU pantry, right? So there is prolapse in our CCU pantry. That's why it's not closing properly. So the consequences is that because the leaflets don't meet properly, there's a direct leakage from regurgitation jet from the left ventricle back into the left atrium during systole. So this sudden volume overload in the left atrium um, can cause it to dilate. Okay, so the secondary mitral regurgitation, it is related to what? The problem stems from the left ventricle. Okay, so this is the pathophysiology. So why do we have to treat mitral regurgitation? So treating mitral regurgitation is very important. We really have. So it still depends. Once you read an echo, you will be able to assess. Like there will be a definition. Okay, trace MR, mild MR, moderate MR, severe MR. So it depends on the severity and the patient's clinical manifestation where the decision for treating is important. Okay, so symptoms for patients with mitral regurgitations are dyspnea, fatigue or topnia, PND, edema due to heart failure. Progression of disease is that left atrial dilation, atrial fibrillation, pulmonary hypertension, left ventricular or the LV remodeling dysfunction, and heart failure, which leads to hospitalizations and increased mortality rate. That's why it will initiate as mild MR. Then afterwards, it will go for moderate to severe MR. So once the disease is not treated or the cause of the cause is not treated, it will progress to certain abnormalities or um, dysfunction of the patient's heart. Left atrial, pulmonary hypertension, LV dysfunction, heart failure, and it can increase the mortality of the patient. So now we have the medical versus surgical management for mitral regurgitation. So remember that primary MR as a valve problem and secondary MR as a ventricle problem. So it is critical and it directly influences how we approach patient selection and the expected outcomes with therapies like the mitral clipping. So we need to know, doctors should assess the patient, and we need to know really what is the type of the patient's mitral regurgitation. So now we have the what we call medical versus surgical management of MR. So medical therapy includes diuretics, ACE inhibitors, or your angiotensin receptor blockers, beta blockers, especially for secondary mitral regurgitation because it will improve your contractility, often to manage heart failure symptoms. But the limitations of this medical therapy is that it, it helps only improve your the patient's feeling regarding the manifestation, but it does not really solve the mechanical issue. It cannot prevent progression of severe MR. So medical therapy plays a really foundational role, especially in patients with chronic MR and heart failure. So the primary goal is that medical therapy is primarily aimed at symptom management and controlling any associated conditions like hypertension or atrial fibrillation, but it does not fix the underlying mechanism or mechanical problem of the leaky valve. Think of it like you are just patching your pipe, you like your faucet, because if there is leakage, you're just patching it, but the hole is still there. It might slow the leak, but it doesn't repair the hole. So diuretics will elevate the fluid volume and reduces symptoms like dyspnea and edema, while ACE inhibitors or ARBs, it reduces the afterload and help in ventricular remodeling. Then we have the what we call the A mineralocorticoid receptor antagonist, such as spironolactone, which is further improve the LV remodeling outcomes in heart failure also. So remember that the reason why we are giving aldactone for our patient is not merely a potassium sparing, but it helps in your left ventricular remodeling for patients with heart failure. Then we have the goal here is to optimize the ventricular function, reduce ventricular volumes, and indirectly reduce the severity of functional MR by improving leaflet coaptation and reducing tethering forces. So the limitations of this medical therapy is that it does not address the mechanical defect. So despite treating or helping reducing the symptoms, but it does not treat the defect. So for severe primary MR, medical therapy cannot correct the anatomical defect. The valve remains leaky and the progressive volume overload of the left atrium and ventricles are still there. So symptoms managed, so limitation of impact. So symptoms and management versus cure. Medical therapy largely focuses on managing symptoms and slowing disease progression, but it does not cure the MR. Then we have the second what? Second, management, the surgical mitral valve repair or replacement. For decades, right? This is the first, like the golden standard, the gold standard of MR, severe MR. Open heart surgery has often been the definitive treatment for severe mitral regurgitations in appropriate candidates. It still remains the gold standard for many patients, especially those with primary MR. So the gold standard is that mitral valve repair whenever feasible. Okay, so um, repair is preferred over replacement, particularly for primary MR. Techniques include annuloplasty to reduce the size of the valve ring, leaflet resection here. They are putting a lot of like sutures, but they have specifications for that. Leaflet resection, chordal replacement, and leaflet application. Repair preserves the patient's own valves, so still the patient's own valves are there and often leads to better long-term ventricular function and survival outcomes. So outcomes, excellent long-term results in appropriate candidates. So the limitation is that this is invasive, like you need to have an open heart surgery. If the patient will undergo for bypass, surgical risk in elderly, frail, or those with multiple comorbidities. Example, those patients with severe lung disease, previous cardiac surgery, or severe renal dysfunction, or porcelain aorta. And also, it requires prolonged recovery as the patient is, of course, it is an open heart surgery. So, this high surgical risk. Many patients with severe MR are elderly and have multiple comorbidities that significantly elevate what do you call that? Significantly elevate the risk for surgery. Like example, advanced age, right? Frailty increases exponentially with age. As the patient go older, the patient also is higher the risk. So severe lung disease for patients COPD patient, it increases the risk for prolonged ventilation and respiratory complications. Severe renal dysfunction, so higher risk of acute kidney injury or worsening CKD. If the patient have previous cardiac surgery, if the patient have previous cardiac surgery, it leads to adhesions and makes reoperation more complex and risky. So if the patient also is having porcelain aorta, there will be like severe calcification of the aorta, making the aortic cross clumping during bypass extremely hazardous. Then severe LV dysfunction in patients with advanced heart failure, the heart may not tolerate the stress during the surgery. So other non-cardiac comorbidities also we have liver disease, active cancer, severe peripheral vascular disease. So prolonged recovery even without complications, recovery from open heart surgery is lengthy process, right? Anything that is really surgical is in compared to non-invasive is recovery is extended compared to transcatheter procedure. Often involves weeks to months of rehabilitation and significant lifestyle disruption. Blood transfusion also, there are higher likelihood of requiring blood transfusion during and after surgery. So it's these significant surgical risks and limitations that have created a critical and meet need for less invasive alternatives. So this paved the way of the development of transcatheter therapies like MitraClip, offering a viable solution for many patients who simply cannot safely undergo traditional surgery. So evolution, sorry. So the evolution of transcatheter mitral valve repair. So we have TAVI, TAVR. Then we also have now transcatheter mitral valve repair. Oh, sorry. So the conceptual basis is that it mimics the surgical edge-to-edge repair and also early development, preclinical studies already, and initially experience already in humans. So mitral clip system is the first approved transcatheter edge-to-edge repair device. So a brief mention of other like annuloplasty, cordial replacement, it acknowledged that MitraClip is one approach among several others. So the MitraClip device and principles. So first, the device components. So this is your mitral valve, right? And this is your, what is this? This is your tricuspid. So this is the process. So this is the atrial view. They will just clip it here. So guide wire. There is a steerable guide catheter. There is what we call CDS, clip delivery system. The mitral clip implant itself, which is cobalt chromium clip with polyester fabric covering, although as far as I know, cobalt is not also a good um, elements. So the mechanism of action is that it grasps the anterior and posterior mitral valve leaflets, creates a double orifice mitral valve, and reduces the mitral regurgitant orifice area. So it decreases also the mitral regurgitation. I will share with you the video in WhatsApp, so it will be easily understood by everyone. So the mitral clip procedure, step by step, of course, what is your nursing responsibility on this process and what should be done to the patient step by step. So of course, patient preparation, NPO. The patient should be on NPO. Make sure the IV patency or there is an IV access and continuous monitoring. Patient will undergo for general anesthesia and is typically used due to the need for TEE. So last week we have 3 successful mitral clipping and all the patient underwent general anesthesia and this is TEE guided. Okay, so vascular access, femoral venous approach, right femoral vein, and there is also transeptal puncture, but in this case we did the femoral access. So guide catheter positioning, advance across the septum into the left atrium, clip deliver system advancement through the guide catheter position above the mitral valve. So TEE guidance is critical for every step. That's why this procedure is not that risky for CKD patient because the contrast is not, they are not administering contrast. If there is, it will be very, very minimal because the guidance of the procedure is done through TEE. So critical for every step, guiding clip alignment, grasping leaflets, assessing MR reduction. So TEE from the start to the middle up to the end of the procedure. So grasping the leaflets, clip is open and advanced into the left ventricle, retracted to capture the leaflets, then close. And then assessment of MR. Once the catheter or the clip is already close to the both leaflets, they have to assess the MR reduction first. Immediately a clip is deployed, T is used to assess residual MR and transmitral gradient. The good thing that we have now, if in case this is like, I think, Abbott products, so they have to reassess first the MR, the gradient, before they will totally deploy the clip. So there is also, if in case needed, there is what we call clipping, repeating the clipping. If MR is still severe, a second clip may be placed. So this is clip and release sheet removal once the doctors or once TEE result gave you a significant reduce in mitral regurgitation, then they will release the clip and remove the sheet. Post-procedure care, of course, hemostasis and access site monitoring. So here, this is the mitral clip, minimally invasive heart valve repair procedure involves implanting a clip in the heart without opening the chest. This is how it is done. So first here, clip and catheter enter the femoral vein. Here, it will enter the femoral vein through the like 1 centimeter incision made in the groin. So it still depends on the size of the catheter, but at least 1 centimeter. Then it will pass to the clip is guided by ultrasound. This is what we did, TEE guided. And then it is visualized upwards through the catheter up to the heart. Then it will pass to your right atrium. Then it will go now here to your left atrium. So there will be an incision between the septum a little. Then the catheter will be passed through that. Then the clip enters the right atrium and crosses into the left atrium above the valve. Then clip enters the damaged mitral valve here, and its two levers clamp the valve shut, reducing backwards flow of the blood. Then catheter is detached from the clip and is withdrawn. So this is the mitral clip or MitraClip. So indications, of course, in general, if the patient is having severe symptomatic primary or secondary MR, high surgical risk determined by heart team. It will be assessed according to the assessment of the surgical team. Of course, they will decide for the procedure. So LV ejection fraction, usually more than 20 to 30% for secondary MR, but it can be variable. Favorable valve anatomy, meaning there is sufficient leaflet. So they will assess really the anatomy of the mitral valve before deciding of mitral valve clipping. No severe calcification at the grasping site, and there is acceptable leaflet motility. So in here, heart team approach emphasize the multidisciplinary discussion. So it is not decided by one surgeon or one cardiologist alone, but multidisciplinary approach. So this procedure is contraindicated for patient with severe rheumatic mitral valve disease, endocarditis, intracardiac thrombus, unfavorable anatomy, like severe leaflet calcification at grasping area and very restrictive leaflets, meaning the clip, there is no leaflet to clip the mitral clip. So the outcomes of outcomes and complications. So this is how it goes. Right femoral vein pass through your right atrium, then it goes through left atrium, then the clip will be attached or deployed in the mitral leaflets. Okay, then it will reduce now the flow because your leaflets is coaptation. So procedural success, highly technical success rates usually more than 90%. And the reduction in MR typically reduces MR to moderate or less. So it has an improved symptoms of heart failure, reduced heart failure hospitalizations, and improve, of course, quality of life. The potential complications includes access site complications like bleeding, hematoma, or can also have pseudoaneurysm. Like cardiac complications include pericardial effusion, tamponade, mitral leaflet damage, or even cordial rupture. Then we have, there will be cases for thromboembolic events like stroke, residual MR, which need for reintervention, mitral stenosis, increased transmitral gradient, usually transient or mild. It can cause also infection, which is rare only, like endocarditis. And of course, as any procedure, the chances of that is also there. But in this mitral valve clipping, that is very low, but still the chances are there. So patient monitoring, it requires close surveillance for complications. So as critical nurses who manage patients with post mitral valve clipping, same with other procedures, our management is very important and our monitoring is very important as the site is a little bit huge for the deployment of the catheter and the what do you call this, the sheets and all. So monitoring of ischemia, lower limb pulses, circulation is very important. Hemoglobin drop, if there is, especially you have to observe whether there are significant bleeding. So post-procedure management includes anticoagulation or antiplatelet therapy. Usually in these cases, we're giving dual antiplatelet therapy like aspirin and clopidogrel for 1 to 6 months, then lifelong aspirin depending on the patient's risk profile. So follow-up echo. So once the patient will arrive in CCU, of course, we have to call for echo to assess the reduction of MR and function of left ventricle. At discharge, another echo follow-up is advised 1 month after procedure and 6 months, then annually. So heart failure management, you have to continue the management or the treatment of the patients and restriction of activity. The patient can gradually, not abrupt, but gradual return to normal activities. So the advantages and limitation of mitral clip is that the advantages choose minimally invasive. So there is no sternotomy, no bypass. So reduce procedural risk complication compared to surgery for high-risk patient, symptomatic improvement, faster recovery, and preserve surgical options in the future. Then limitations, it is not a complete cure for MR. There is still what we call residual from mild to moderate MR, not suitable for all anatomies. That's why assessment is very important. Potential for reintervention or if there is like late failure. So reintervention is also advisable in the future if in case there is again recurrence of MR. So the cost here is quite expensive, of course, as this is valve. Same with TAVI, the valve is also expensive. Same with mitral clipping, the valve is also expensive. So long-term durability is still being studied compared to surgery. That's why even up to now, the golden standard treatment for severe MR still the surgery. So conclusion, MitraClip represents a significant advance in the treatment of severe MR for high-risk and inoperable patients. It offers a safe and effective transcatheter option to reduce MR, improve symptoms, and reduce heart failure hospitalizations. A meticulous heart team approach is essential for optimal patient selection, and the field of transcatheter mitral valve replacement or implant is rapidly evolving, promising further innovation. So in these cases, um, uh, mitral clipping is really plays a significant role in innovation. So any patient that requires high risk, there is an increased risk to develop an increased risk for surgery. So at least now there is already an option for the procedure. Okay, that ends my lecture. It's just a short brief. I will try to arrange new lecture which really focuses on our management from pre-procedure, even intra-procedure, and post-procedure. I will further elaborate that, and I will share the video in WhatsApp, like how the flow of the procedure really in this process of mitral clipping. Do you have any questions? Um, I will ask some questions, okay? Hagar, are you there?
Yes, ate. Good morning.
Okay. How can you differentiate between primary MR and secondary MR?
Primary MR meaning this the degenerative meaning there is abnormality, structural like that abnormality in the valve. And secondary This is the functional or ischemic, right?
Yes. Yes,
It's,
yes. It's really related
I'm not
like that. Yes.
remembering. Yeah.
Yes, of course. Okay.
Uh, mm,
So,
okay.
um, thank you, dear.
Okay.
So as seen here, as we discussed earlier, primary and secondary, right? So for primary, as you said, there is leaflet prolapse. It's the anatomy itself, right? The anatomy of the valve. While for secondary, it can be related to the ventricles. Okay. So I will ask again. Who is the lucky girl? Let me see. Marwa. Marwa, are you there?
Yes, ate. Good morning.
Okay. What are the, give me an example of medical treatment for patients with MR.
Diuretic. The first
Yes.
thing. ايه تاني؟
What else?
Mm,
What medications we are giving to have like it leads or
Beta
improves
blocker.
the left ventricular remodeling?
Beta blocker.
Another answer. So we have the ACE inhibitor or the ARBs. Okay, so medications or the treatment, medical treatment for patients with mitral regurgitation. We discussed, yeah, we have medical therapy, right? Medical therapy, surgical repair. So the medications includes diuretics, ACE inhibitor and ARBs, beta blockers, and the medications that improves in your left ventricular remodeling is your ACE on or the ARBs, okay, or angiotensin receptor blocker. Okay.
Okay.
Um, Mary Ann, at the Mary Ann.
Yes, Ma'am Tin.
Okay,
Morning.
can you give us a short brief or summary of the flow of the procedure? In the procedure, how does it goes? Inserted from where to where? How does it go?
For-
So the flow of mitral clipping.
So the catheter will be inserted starting from the femoral. The catheter will enter in the femoral, and then it goes to left to the right atrium, and then to the left atrium,
Okay.
and then this the catheter will be guided. The clip will be guided through ultrasound, and then clip will be guided through ultrasound, and then it will goes up, move upward to the catheter, to the heart, and then from the left atrium it will goes down to the right atrium, and no, no, it will goes, it will enter to the right atrium, crosses to the left atrium above the bulb. Is that right?
Yes. Okay. So Amara, can you repeat what Ate Mary Ann and elaborate further the process of mitral clipping?
They will use a guide wire, and they will process through the femoral side to left atrium, then to the right atrium, and then they will use the clip to close the both leaflets, and when it's clipped, then they will remove the guide wire.
So is it femoral vein or femoral artery?
Femoral vein.
Femoral vein.
Okay, femoral veins. Okay, so mitral clipping first. A clip and a catheter enters the femoral vein through like incision. Remember, it is what we call TEE guidance. So we have TTE, that is transthoracic echocardiography, that is different from TEE. TEE is transesophageal echocardiography. So this is the guidance or the eyes of all the process of a mitral clipping. So first, a catheter is inserted into the right femoral vein. Then the clip is guided by TEE, and then it moves upwards to the catheter, to the heart, to your right atrium. Then it crosses into the left atrium just above your mitral valve. Then the clip enters the damaged mitral valve and it will clamp the valves. Okay, so the TE, the mitral regurgitation is assessed before and also before totally deploying the clip or mitral clip. The mitral regurgitation is assessed again whether there is significant reduction or it's still there is um, severe regurgitation. If in case the first clip does not give a satisfactory reduce in MR, then another clip can be deployed until successful reduction of mitral regurgitation is achieved. Okay, so don't forget that any procedure that we will have. Thank you so much, by the way. Thank you so much, guys, for attending the lecture. I know you are really trying to not to go under the sun to the building two for the classroom, but thank you for attending and hopefully you pay attention to the lectures. I will send and share in the group the exam, and any one who will not pass will not do the exam. Of course, there is no your attendance will be based on the exam. Okay. Hopefully you learned something. uh, if you have any questions you can message me and you can relay your additional input for the procedure, and hopefully the procedure last week will not be the last. It will be our first but not the last, so we can further understand really the mechanism and the process of the procedure. Okay, any questions? Are we all clear? Thank you so much for the cardiovascular trainees who attended the lecture also. Appreciate much for your attendance. And Narjana and Fatma is there also. And of course, my CCU colleagues. Okay, continue studying and remember, knowledge is power. And we need to make sure that we are safe in handling your patients. Okay, you can exit the chat. I mean the meeting, and you can enjoy your day. And those who are going for night, you can take rest and prepare for your duty later. Bye bye.
Bye, ma'am. I miss you all.
1 week na lang.
Wag ganun, ma'am. Bye-bye. See ya.
Mhm.